Good morning, everyone. Today we are discussing about antihypertensive drugs. Through this lecture, the students can able to understand about physiology of blood pressure, hypertension, pathophysiology of hypertension, and pharmacology of hypertension. So first of all, let's discuss about hypertension and its pathophysiology. Hypertension means sustained increase in blood pressure. A normal means a systolic pressure would be more than 140 mm of Hg and diastolic pressure maximum or more than 90 mm of Hg, whereas a normal blood pressure of our body is less than 130 systolic pressure and less than 85 diastolic pressure. A mild hypertension we can say if it is plus 20 of systolic normal pressure, it would be a moderate if it is plus 40, and it would be a severe if it is plus 80, and it is calling a malignant if blood pressure is more than 210 of the systolic pressure and 120 of the diastolic pressure. Hypertension is a silent killer. It is a painless complications. Various complications of hypertension are dizziness, headache, and visual difficulties. It is the leading risk factor for myocardial infarction, DM, and stroke. It is responsible for the majority of office visits. A number one reason for drug prescription. A 25% of population in which 35 less than 35% are aware. Complications brings to diagnosis but late, and chronic end organ and vascular damages are the later symptoms or later outcomes of the long-term hypertension. Now let's discuss about the regulation of blood pressure. Uh, Blood pressure call a cardiac output multiplied by peripheral resistance. So various factors are involved in regulation of blood pressure. First factor is endocrine factor. Under endocrine factors are renin, angiotensin, ANP, ADH, and aldosterone. Second factor is a neural factor such as sympathetic and parasympathetic factor. Third is blood volume such as sodium, mineralocorticoids, ANP. Fourth is cardiac factor such as heart rate and contractility. Now discuss about etiological classification. First is essential hypertension. It is also calling as primary hypertension, which accounts for 95% of hypertensive patients. Its etiology is unknown. It is due to lifestyle or genetic or hereditary factors. Second is secondary hypertension, which accounts for 5 to 10%. Under this one, first factor is renal, second endocrine, third vascular, and fourth neurogenic factors. Now, secondary, here the known or the reason is unknown. The renal disorders, that is a renin-angiotensin, sodium retention, ADH, and aldosterone, may be a causes. Then Cushing's pheochromocytoma may be a reason. Then essential hypertension. Etiology is a multifactorial, means lot of factors are involved, such as increased peripheral resistance, stress, hormonal, neural, genetic factors, familial factors, and lifestyle factors. Now, let's discuss about pathogenesis of renovascular hypertension. So through this chart, we can see when the glomerular filtration rate getting down, on that time, juxtaglomerular aldosterone is activating, which causing a angiotensin that increases sodium retention and increases blood volume. On the other side, it also causes vasoconstrictions, which increases peripheral resistance, and later they causes hypertension. Let's discuss about malignant hypertension. It is a rapidly progressive end organ damage, may complicate any type of hypertension. Artery necrosis with thrombosis may cause. Rapidly developing renal failure may cause. Hypertension encephalopathy may occur. Left ventricular failure may cause, and less time no hypertrophy may cause. Now, morphology. A large blood vessels, that is calling a macroangiopathy. Under this one, atherosclerosis and its complication may occur. Small blood vessels, that is a microangiopathy. A hyperplastic atherosclerosis, that is also calling a thickness of arterioles, may occur. Then heart. Under heart, left ventricle hypertension, hypertensive cardiomyopathy, IST, myocardial infarctions may occur. Under kidney, benign nephrosclerosis may occur. Under eye, hypertensive retinopathy may occur. In our brain, hemorrhage, infarction, splinter hemorrhage, and lacunar infarcts may occur. Now next, pathogenesis of vascular changes. Through this image, you can see arteriosclerosis, rupture, aneurysms, rupture may occur, which can cause a ischemia, aneurysm, or rupture of the normal vascular to the diseased vascular. In this figure, you can see some of the factors involved in controlling of blood pressure. that affect the basic equation, that is blood pressure, cardiac output into peripheral resistance. So excessive sodium intake, reduced nephron number, stress, genetic alteration, obesity, endothelium derived factors. These all factors are involved in the hypertension. You can see through this image, these all factors may increase the sodium renal retention, decrease filtration surface, increase sympathetic nervous activation, increase renin-angiotensin, cell membrane alteration, and hyperinsulinemia, which further causes increased in preload, increase in contractibility, functional constriction, and structural hypertrophy, which further causes a hypertension that is due to increased cardiac output and increased peripheral resistance. So this is the mechanism how this hypertension causing in our body. Here in this image you can see a slide of a heart vascular of the left ventricle hypertrophy. You can see a this image of this one, the left ventricle part, how it is become a inflamed or become a balloon shape, or thickness of the vessels you can see in this image. So this is the sample or example of left ventricular hypertrophy. This is the hyperplastic atherosclerosis. So here histopathological images they have shown. In this histopathological images they have shown a narrow of the middle part, that is a lumen, and the thickness of the valve. Here they are showing the nephrosclerosis in hypertensions. Again you can see a sclerosis, arteriosclerosis. Here you can see a narrowing of the arteries or the lumen part. Same they have shown here. Next. You can see here benign nephrosclerosis that is causing due to the continuously high blood pressure in our body. You can see a cerebral infarctions. If we are not going to treat hypertension, then it may damage your brain, it may damage your cerebral part. Renal cause, under the renal causes, renal artery atherosclerosis, polycystic disease, glomerulonephritis, renal artery stenosis, renal vasculitis, renin producing tumors. So you can see a polycystic kidney image which is caused due to the chronic hypertension phase. Another example of uh, lethargy, leather granularity benign nephrosclerosis image. A normal retina fundoscopy, you can see a normal image of retina. Now you can see a hypertensive retina, how it is damaging our retina if it is long-term hypertension is going on. So a hypertensive retinopathy, atherosclerosis cause the arterial light reflex to become broad and dull silver wire. A generalized or focal retinal atrial constrictions, which is pale in color, a superficial flame-shaped hemorrhage, small white foci of retinal ischemia, a yellow hard exudates due to lipid depositions deep in the retina. There is a different type of grades are there in the retinopathy. Those are grade 1 thickening of arterioles, grade 2 focal atrial spasm, vein constriction, grade 3, hemorrhages, a flame shaped dot blot, and coated wool, and hard waxy exudates, a grade 4 papilloedema. So now let's discuss about the pharmacology of hypertensive drugs. So the normal blood pressure and the hypertensive blood pressures we have already discussed. So once again we are discussing here. So pre-normal blood pressure of our body is 120 less than 120 or equal to 120 by 80. Now, in a pre-hypertension phase, it may be 120 to 139 systolic pressure and 80 to 89 diastolic pressure. Whereas in the hypertensive stage 1, the blood pressure systolic blood pressure may reach from 140 to 159 and diastolic 90 to 99. In hypertensive stage 2 phase, it may reach more than 160 systolic pressure and 100 diastolic pressure. In case of emergency, it may reach 1 210 systolic pressure and 120 more than diastolic pressure. Resistant hypertension, a failure of blood pressure control with drugs, that is calling a resistant hypertension. Now, how can we treat hypertension? A secondary hypertension treat underlying causes. Essential hypertension causes are not known. Factors involved stress, weight, dietary habits, salt retention, increased angiotensin production, increased sympathetic tone. Approaches reduce salt or water content of body, reduced sympathetic tone, reduced effects of circulating angiotensin 2, reduced cardiac force of contraction, dilate peripheral vessels to reduce cardiac filling and consequent stroke volume. Drugs used for treatment of hypertension are diuretics, centrally acting agent such as methyl dopa and clonidine, beta beta adenoreceptor blockers, alpha adenoreceptors blockers, combined alpha and beta blockers, ACE inhibitors, angiotensin receptors blockers, calcium channel blockers, and vasodilators. So these are the classifications of the drugs for the treatment of hypertension. Need for change lifestyle for treating the hypertension. So the basic aim for the need are the weight loss or control, restricted sodium intake, increased aerobic exercise, moderating alcohol consumptions. These changes in lifestyle may be sufficient to control hypertension in early stage 1. They also facilitate pharmacological treatment. So let's discuss first drug class of drug, that is diuretics. Examples are thiazide, loop diuretics, and potassium sparing diuretics. They are antihypertensive when given alone, also enhances the efficacy of other antihypertensive agents. Exact mechanism are unknown. Initially decreases extracellular volume and enhances sodium excretions by inhibiting sodium chloride cotransporter, which leads to reduce in cardiac output. A long-term therapy, a cardiac output and extracellular volume returns to pre-treatment value due to compensatory mechanisms, but antihypertensive effects persist due to decrease in peripheral resistance. Next, reduce in peripheral resistance may occur due to direct vasodilatory effect of thiazides or due to their effect on kidney. Thiazide should be avoided in patients with concomitant diabetes mellitus, gout, hyperlipidemia, renal insufficiency. A high efficacy diuretics, that is also calling as ceiling diuretics. A severe reduction in blood volume and electrolyte imbalance. Strong diuretic, a weak antihypertensive than thiazide diuretics, indicate in hypertension when complicated by chronic renal failure, coexisting congestive heart failure, severe edema due to use of potent vasodilators. Sympatholytic agents centrally acting examples are methyl dopa alpha and clonidine. Next, beta adrenergic blockers, alpha adenoreceptor blockers, and combined alpha and beta adenoreceptors blocker such as labetalol and carvedilol. Methyl dopa. It is an analog of dopa, that is a dihydroxyphenylalanine. It is a prodrug metabolized in brain by alpha by L-aromatic amino acid decarboxylase in adrenergic neuron to alpha methyl dopamine and then converted to alpha methyl norepinephrine. Alpha methyl Norepinephrine is stored in the vesicles in place of norepinephrine and released in response to stimulus, acts in the CNS to reduce sympathetic outflow from brain stem, also probably acts an antagonist to of central presynaptic alpha 2 receptors to reduce central sympathetic outflow. A rapidly absorbed T half-life approximately 2 hours even after intravenous injections effects start after a delay of about 6 to 8 hours. Why the delay in action? Probably due to time taken for transportation to brain and conversion to methyl norepinephrine. Adverse drug reactions are sedation, dryness of mouth, Parkinsonism sign, hyperprolactinemia leading to gynecomastia or galactorrhea, clonidine, guanabans, and guanafacine stimulates alpha 2A subtypes of alpha 2 receptors in the brain stem and reduce the central sympathetic outflow. It reduces in plasma concentration of norepinephrine correlates with the decrease in blood pressure. A decreased sympathetic outflow also reduces cardiac output and heart rate. In spine position, when the sympathetic tone to vasculature is low, the effect is mainly by reducing heart rate and stroke volume. In upright position, the vasculature tone is high and effect is mainly by reducing the peripheral resistance since they block peripheral vasoconstrictions postural hypotension may occur. Adverse drug reactions are sedation, xerostomia, dryness of eye, nasal mucosa, parotid swelling, postural hypotension, erectile dysfunction, bradycardia, sinus arrest, AV block, rebound hypertension, a guanadril. It's a exogenous false neurotransmitter actively transported to adrenergic neuron by norepinephrine transporter. Previously, norepinephrine transporter was known as uptake 1. It is stored in adrenergic neurons where it is concentrated in storage vesicles and replace norepinephrine. Released in place of norepinephrine and act as a false neurotransmitter. It has no activity on adrenergic receptor. This inhibits the functioning of peripheral adrenergic neurons. Antihypertensive effect is achieved by reduction in peripheral vascular resistance and postural hypotension. Beta adrenergic blockers, it decrease heart rate, output, and stroke volume by blocking beta 1 adrenergic receptors. It inhibits renin release from juxtaglomerular apparatus by blocking beta 1 adrenergic receptor. Block beta receptors of peripheral blood vessels so they constrict. By blocking beta 2 receptors, a peripheral vascular resistance increases initially but gradually returns to pre-treatment values or less. Those crossing the blood-brain barrier also reduce central sympathetic tone. Do not cause a retention of salt and water, often combined with diuretics additive effect. Highly preferred drugs for hypertensive patients with complications like angina, myocardial infarction, and congestive heart failure. Next, beta adrenoreceptors blocker procedure produces decreased myocardial contraction and cardiac output by blocking beta 1 receptors, decrease renin secretions by blocking beta 1 receptors, decrease central sympathetic activity by blocking presynaptic beta 2 effect. All beta adrenoreceptors blockers produces reduced exercise tolerance, mild chronic fatigue, sedation, increased airway resistance, bradycardia, sleep disturbance which will release or reduce melatonin release. All beta adrenoreceptors blockers initially produce vasoconstrictions by blocking vascular beta receptors that relax vascular smooth muscles. This vasoconstriction disappears after some time. Beta adrenoreceptor blocker with intrinsic sympathomimetic activity. Advantages are less bradycardia and myocardial suppression, useful in patients having low cardiac reserve, less likely rebound hypertension, less worsening of lipid profile, less effect on exercise tolerance. Beta adenoreceptor blockers with intrinsic activity are oxyprenolol, pindolol, penbutolol, and sibutolol. Nebivolol. It is a beta 1 selective antagonist. It promotes vasodilation due to increased production of nitric oxide in arterial smooth muscle, has a antioxidant property also. Alpha 1 adenoreceptor blocker reduce arteriolar resistance and increased venous capacitance, reflects increased in heart rate and plasma, renin activity, return to normal during long-term therapy. Postural hypertension may occur depending on plasma volume. Reduce total plasma concentration of triglyceride and low density lipoprotein. Increased plasma level of high density lipoprotein, it's a beneficial effect. Effect on lipids persists even when combined with diuretics. It preferred in hypertensive patients with BPH. Combined alpha and beta adenoreceptor blockers, labetalol and carvedilol. Labetalol is a mixture of four stereoisomers. One isomer is alpha blocker like parajosin, prajosin. Another is a non-selective beta blockers with partial agonist activity like pindolol. Other two isomers are inactive. A cardivolol is a beta receptors antagonist with alpha 1 receptors blocking activity, pheochromocytoma. Vasodilators example is a hydralazine. It directly relaxes the arteriolar smooth muscle, a mechanism uncertain, does not relax venous smooth muscle. Compensatory reflex increase in sympathetic outflow, increase in heart rate, cardiac output, plasma renin activity, and fluid retention. Selective decrease in vascular resistance in coronary, cerebral, and renal vascular beds. At postural hypertension, uncommon because it does not dilate veins. Adverse drug reactions, extension of pharmacological effects such as headache, flushing, hypotension, palpitation, tachycardia, dizziness, and nausea can precipitate angina and myocardial infarction due to increased myocardial oxygen demand. Immunological reactions are drug-induced lupus syndrome, serum sickness, and hemolytic anemia. Pyridoxine responsive polyneuropathy, probably because hydralazine combines with pyridoxine to form hydrazone. Minoxidil, converted in liver to active form, minoxidil nitric oxide sulfate, produces arteriolar vasodilation. No effects on venous capacitance vessels, causes increased in cardiac output, blood flow to skin, skeletal muscles, GIT, and heart is increased, dilates the renal artery. Net effect depend on hypotension and extension of dilation. Potent stimulator of renin secretion by increasing sympathetic outflow and affecting renal regulation of renin release. Minoxidil sulfate open ATP modulated potassium channels. Potassium efflux occurs, cell is hyperpolarized, may precipitate severe bradycardia, sinus arrest, hepatotoxicity, Cobb's test, that is antiglobulin, necessary because autoantibodies are produced against Rh antigen, preferred drugs for treatment of hypertension during pregnancy. Adverse drug effect on cardiovascular system, same like hydralazine, hypertrichosis, that is abnormal hair growth in body, may occur. Its uses are severe hypertension treatment should never be given alone, always with a diuretic to prevent fluid retention and a sympatholytic drug to control reflex CVS changes and badness typical. So like that we have completed our this chapter. Remaining part we will continue tomorrow. Thanks a lot.